It's a commercial business over here.
Yeah,
Nothing more than that.
unfortunately, people like me don't do that. Anyway, so go on, Ali. This is a picture which
Yes,
is
and
most exam wire will start with a prop. So the prop here is this is an X-ray of a pelvis, and I'm showing this to you. And I want you to comment on this, please, if you don't mind. Yeah.
sorry, uh, uh, what did you say in the end?
Sorry, I can't hear you. You need to be a bit louder.
Okay. And this is an AP radiograph of pelvis with both hip joints, and it shows implants in place, which is total hip arthroplasty implants. And I can see that if I start on the right side, it seems like it's a cemented total hip arthroplasty implant on the right side with cement um, cement metal seen all around the femoral stem.
Okay,
And
so let me correct you now. In the exam, it's all about money. Okay, what you say is
yeah,
making money for you in the bank. So you would say
okay,
this is an X-ray of a pelvis, which shows cemented total hip replacements on both sides. Okay, the
yeah,
left one, your left and my left. The left one shows what
left,
looks like a taper implant, which is probably a Zimmer or one of those. What do you call them? The double taper implant, which looks okay. It's not perfect, but it looks okay.
uh,
And cemented implant. Yeah. On the left side, however, it looks like there is a monoblock Chanley cemented
yeah,
implant, but there are loosening. Okay. Now, if you say this
loose
in
and
the first
center.
minute or so, you have already scored the maximum amount of points you want to say. Okay. So,
Okay.
so go on now. Tell me on the loosening of the right side. If you look at the right side, what is the? Oh, sorry, the left side of the hip implant. What's the loosening? Loosening. Describe that.
Yeah,
Yeah.
it's yeah. On the left side, it seems like the implant is loose. There is osteolysis and the ballooning of the cortex is even seen around the stem, and it could be Vancouver zones. I think zone. I don't remember those zones now.
So you need to know these are the
Three. Yeah.
Gurin zone, yeah, and the Charlie DD
Yeah.
for the stem for the cup and the Gurin zone for the stem. To easily
Yeah.
say that there is loosening in all zones of the femur and probably half of the zones in the acetabulum, yeah. So
Yeah.
all the zones on the femur shows loosening, and
Losing.
the cup also looks loose. Okay. So what
Yeah.
is your plan for this patient? How would you go ahead for this?
Yes, we would have to go ahead and do the metabolic profile. First of all, we have to rule out the infection in this patient.
Okay.
The definitive plan for this patient would be uh, to revise the
Okay,
component.
so revision
But
comes
that would be
later. You
done.
need to first of
Yeah,
all make sure that the patient can be helped. You need to also make sure that the patient needs revision, and the thing is that the patient is good enough to have revision. Okay, so the first
yeah,
thing is, does this patient need revision? The answer to that is you can see osteolysis and loosening in nearly all zones of the femur and the cup line.
yes,
Okay, so now you
yes.
want to make sure whether this is aseptic or septic loosening. Okay.
Yeah, we would have to know that it is painful. Like it should, from looking at this picture, it seems like it should be a painful prosthesis for the patient.
Okay, so you can't
We would
assume
have,
on the pictures. Okay, so you
yeah,
want
we would
to know
have to
whether
ask
this
the
is
patient.
septic or aseptic, and how will you do that?
Yes, we would have to do baseline blood labs, but like blood CPE, CBC, ESR, and CRP. And the best thing would be to aspirate the joint.
Okay,
And
so the start of all this is you would like to do an FBC ANA. Which blood tests are the ones you
CBC,
want to do?
ESR,
Okay,
ESR, and CRP.
okay. So what's the difference between the two, ESR and CRP? What will they tell you?
ESR usually is raised in a chronic infection,
Okay,
and CRP tells us an active infection
okay. So whether it's an acute or
involved.
a chronic phenomena, that's what it's going to
Yeah.
tell you.
Yes.
Okay. So now you've done the bloods and it's come back as normal. Your CRP and ESR is not raised. Okay. What are
Hmm.
you going to do now?
I would like to aspirate the hip joint
Okay, good.
and send for cytology and cultures.
So why cytology? See, don't say things that are
Uh,
going to wake the examiner up. Why
okay.
do you want to do
Like
cytology here?
to look for the uh, mm, look for the osteolysis if there is any.
So you don't do cytology. What you do is you take the
Okay,
aspirate and you
cultures.
cells, white blood cells, and you also ask them to culture it for you. Like, okay, so
Yeah.
so what is the incidence of an aspirate coming positive? If you take an aspirate, what is the chance of first of all getting an aspirate, and secondly, what is the chance of that aspirate actually giving you a positive result for infection?
I don't know the actual figures.
50%. Okay. So there's a 50% chance that you will get an aspirate, and if you don't get an aspirate, you can inject sterile saline into it and then re-aspirate it again. And of that 50% that will come back again, only 50% are positive, i.e. they will show you cells, okay? But it's an important thing that you have to mention in the exam. What if this patient had infection? What would you do next? Suppose the test came back and your aspirate shows a gram-positive cocci or Staph aureus or whatever you want to call it, and your ESR is 100 and your CRP is 250.
Okay. The thing is, we would have to take it down. We would have to remove the implant.
We would have to mean that
because
life and death. You can't not do it. Okay, so you can't use those statements in the exam. Unfortunately, exam is also a language. So you would say, I will, assuming that there is no contraindication to surgery, I would like to control the infection. Okay, and how do you control infection?
We would have to explant.
So you can take the implant out.
Yeah, and we would
have
to
treat it. So I do a two-stage procedure. Yes.
Yes, they
take the implant out. What
two stages. We would have to do a thorough debridement, take out all the
good. You've done that. What
debris else? Over there.
What else?
We can put some antibiotic prostolac sort of an prosthesis to.
So you need to put a spacer. Okay, that's the correct word. You need to put a spacer in there. Why do you want to put a spacer in there?
To reduce the dead space.
Is what, sorry?
And to reduce the dead space over there.
Not necessarily, but yeah, the other thing is you want to keep the tension of the muscles intact so that when you put it back in, it'll work, yeah?
Yeah.
So what's secondly, a kiwi hip?
Sorry?
What's a kiwi hip? Kiwi?
No idea.
Okay. So when you have an implant like this that you want to take out and you put a spacer in, you can make a spacer from a cement with your hand. You can make a spacer by having these plastic, implants that you put cement in, and it will make the shape of the size you want to put in. Or you do what is called a kiwi hip. A kiwi hip is where you take the implant and you cement it back again into from where you've taken it out after you've done a debridement, but your cementing is not very good, which means it is very loose. So when you want to take it out, the whole implant with the cement will come out. It's called a kiwi hip. And the reason it's called a kiwi hip is when first in these hip replacement and revisions were done, the kiwi surgeons were not very good at cementing, so they used to do poor cementing. And therefore, we now call it the kiwi hip because you put an implant with cement on it to do like a hip replacement, but not doing a third generation cementing technique, so that when your infection settles down, you can take the implant out and you can re-implant things into it. Okay. So how will you know that the infection is settled?
It's quite racist.
Sorry?
It's quite
well, it's not racist. Quite a racist. It's what everybody calls the kiwi hip. Like, but basically for you can put a cement spacer that you can make by hand. You can make a cement spacer that you can make through a plastic, what do you call it?
Yes. We used to make it on like a chest tube.
You can do that, or you can, there is now molds coming or casts coming that take the shape and you can put it and then put it in. They're coming for shoulders, hips, and knees and everything. Or you can do what is called a cemented total hip replacement again, but not doing the cementing techniques right. You don't have to call it the kiwi hip. You just say these are the three options you have. How do you know that the patient's infection is controlled and you're happy to do the second stage?
The first thing is to do a thorough debridement, and then
you've done all that now. You've put a spacer in now. You've come out and you've closed the hip. So now, how do you know that the infection is under control?
We would start the antibiotics, and we will follow with the.
Done that. How would you know that the infection is getting under control?
Serial CRP monitoring.
Serial CRP monitoring. Very good. So how do you know from serial CRP monitoring that the infection is under control?
By 5 to 6 days of a proper treatment.
The correct answer is
going down.
You have to have 3 downward trend of CRP below double figures 2 weeks apart.
Okay.
Okay.
Three.
So if I do a debridement and everything today, 2 weeks later I will do another CRP. Then 2 weeks later I will do another CRP. So when 3 consecutive CRPs are below 10, 2 weeks apart, that means 6 weeks it has to be below 0, below 10 before you can say that the infection is under control. Okay. So your white cell count will show that, but the correct way of doing this is to do a CRP 2 weeks apart with 3 readings below 10. Okay,
Is there a role of procalcitonin?
Yes, that's a model way of looking at it. It's very unusual for every center to have procalcitonin. But if you mention this in the exam, then you have to know everything about procalcitonin. If they ask you, then you can talk about it. I'd prefer if you talk about CRPs because that's what everybody does, like, isn't it? But yes, procalcitonin is the new thing. It will tell you whether the infection is settling, getting worse, or getting bad. Like, so you can do that, and you can talk about it provided you are happy to talk about it. So it's not a contraindication to talk about, but you need to know. So now that you've decided that this is settled, infection is done, you've got a spacer in there, patient is now coming back for stage 2 or stage 2 of your revisions. How are you going to plan this?
We would have to keep plan for a cemented revision arthroplasty.
So you're committing yourself to cemented revision arthroplasty. Not everybody does cemented revision arthroplasty.
I would like to have antibiotic over there.
Yes. So you need to have a choice. Your choices are either you do a cemented or an uncemented revision. Okay. The revision stem should be, if you're doing an uncemented, a distal fix.
Yes.
Okay, and it should go at least 3 diameters of the stem beyond the loosening. So if you can see the loosening is here, it needs to go back. So it has to be a longer stem. Revision stems are always longer stem. Okay, yes. And you need to have a cemented or non-cemented option. Sorry, guys, can you not talk if you are doing this?
Hello.
Okay. So you have a cemented or uncemented option?
Yes, sir.
Okay. Guys, come on, please. I'm doing this, so you don't need to talk while we're doing this. Either you pay attention or not pay attention at all, like, isn't it? And come on, leave and let others study. Okay. So you have a cemented or uncemented options. The cemented option will have to have antibiotic into the cement to allow you to function. It has to be a longer step, and you have to have modality available where you can augment, do the tension lengthening or do whatever, or you can do a uncemented one, which is a distal fix implant, which is a longer implant. These are your basics of revisions. Okay, you happy with that? Okay, so who's next? Does anybody want to do any? Who's next?
May I?
Okay, have a look at this.
Hello.
So who's this next now? Rafi.
Yes, sir. Sir, can you hear me?
Yes, I can. Okay, so this is a 65-year-old gentleman who was gardening. When he finished his gardening, he came up to tell you that this is what he's found. He's got a pain-free lump in his shoulder or in his mid-arm. What do you think this is?
Sir, I would take his history regarding his trauma.
So I just told you he was working in the garden.
He was just working in the garden?
Yeah.
There is no history of trauma.
Well, if he's working in the garden, how do you know there's no history of trauma?
This is what I will inquire about the trauma.
So if he has trauma, what normal trauma? See, the thing in the exam is you have to come with a diagnosis first. You can't just say that I'm going to take history examinations. I've asked you, I've shown you, I've given you a history, and I want you to tell me what this is. So this is a gentleman who was working in the garden, and after working in the garden all day yesterday, this morning he noticed that he has a swelling in his arm, in his forearm. So what do you think that is?
It's a ruptured biceps.
Okay, so it is complete the answer. It is a ruptured long head of the biceps. Yes.
Brachy.
It is a long head of the biceps. Can the biceps be ruptured distally or proximally? And if it's proximally, because it's biceps, it can be from the coracoid or it can be from intra-articular. So this is the long head of biceps 10. What is the management for this?
Sir, depends upon patient's functional demand, dominancy of the hand, number one. Secondly, the functional demand, because patient's age is 65 years, so can it be can be managed conservatively if patient?
Okay, so tell me, what operation do you know that you can manage the proximal biceps tendon that is ruptured naturally to fix it? What operation do you know?
Sir, initially, naturally, I don't fix it.
Yeah, they're non-operative management, okay? They lose about 15% of function, okay? But they are all fully functional and they can go back to normal. It takes about 6 to 12 weeks to settle down, okay? So they will lose some strength,
Yes,
they will have a cosmetic deficiency. What's the other thing that actually some of these patients have?
Sir, weakness of supination.
No, they have dragging sensation, and it allows some of the nerves to be stretched, and therefore they have some hypersensitivity and some paresthesia. But normally this happens in the middle-aged people following work, which means minor trauma. They already have some sort of cuff problem and the biceps tears. And when the biceps tear, they have this lump. This is called the Popeye sign, and they are always managed non-operatively. If you stitch them and put them in the intertubercular groove, you can do a cosmetic realignment for them, but they never get the function and power back. So they will lose 15% of function and power. Okay?
Okay, sir. Sir, even if patient, this is dominant hand?
Even if it's dominant hand, the only time you're going to do a biceps tenodesis is when you do it yourself. So if you cut the biceps, if you're repairing a subscap or something else, then you can do a biceps tenodesis. But if nature cuts it, then you don't have to do anything with it. They heal without doing anything to them. Okay, so who's next?
Sir, can I ask some questions regarding the previous?
Yeah, okay, you can ask questions, yeah.
Yeah, sometimes they rupture at the radial tuberosity.
So that's a distal tear, not a proximal tear.
And
a distal tear you have to repair.
Hello.
No, thank you.
So for the biceps tendon ruptures or tears in two, proximal or distal. In the proximal one, the commonest one is from the detachment from the intra-articular part of the shoulder. Yes, hello. How can I help you? Are you asking a question? Okay, so if it's ruptured proximally and it's a long head, you don't need to do anything with them. If it ruptures from the coracoid, then you have to reattach it, because that you have to put back on and you have to stitch it back with a screw. But if it detaches distally, they all need fixing. And
I'm so sorry, sir. I can't hear you. I think you also can't hear me.
I can hear you.
I don't know where is the problem.
It must be on your side. Everybody else can hear me and we can hear everybody else. So you must look at your own work.
Yeah, we can hear you nice and clear. So if it is ruptured from the around the shoulder, we can leave it as it is.
Yes, if it's ruptured from the intra-articular surface, which is the long head. If the short head is gone, then you have to fix that back on, which is unusual and rare. Less than 1% people have a detachment from the coracoid. They're all intra-articular long head biceps tears. The distal ones you have to fix.
In those patients which present with the spontaneous rupture of the long head, intra-articular long head, they must be having some pain in the shoulder, anterior shoulder pain. Or
so they settle down with the first couple of weeks. The cosmetic deformity does not go away, and they lose 15% of the function, but they go back to normal again. They have no long-term consequences, none whatsoever.
The idea was that they could give a history of recurring shoulder pains or these things.
So previously, yes. They normally have a cuff problem. All of them have a cuff problem. So the biceps is in a groove. If you remember, the biceps in a groove in the shoulder. So if they have some sort of shoulder problem, then the biceps either dislocates from its groove or rubs into the groove and therefore it tears. So there has to be a pathology in the past. They must have something going on to their shoulder, or they must have worked excessively somewhere about a day before, where the next morning they have this.
So this rupture would actually give them relief of their shoulder pain, isn't it?
Depends. So if you have done a shoulder replacement and the biceps tendon ruptures, then the pain will get better. However, if you have a cuff problem, and the biceps is one of the structures that hold the shoulder from going proximal migration, and if that tears, the pain may or may not get better, but they certainly get the humerus then touching the acromion, and that's a different story altogether, and they have more pain from there then.
Okay, thanks. Let us know.
Okay, so who's next?
Yes, sir. I want to do it.
What's your name, sir?
Arif Ali.
Okay. Did you not do the first one?
No, sir, I didn't.
Okay, go on then. This is a 49-year-old lady. She's come to see you because she have left-sided knee pain, and she's in pain for the last 6 months, and she wants you to see if you can help her. So these are X-rays, AP and lateral of this particular lady who has come to see us.
So I have to describe the X-rays.
Yes, please comment the X-ray.
So this is the X-ray of a 49-year-old lady, left the AP and the lateral views. So the AP view is showing there is narrowing of the medial compartment, the joint space narrowing.
So there is narrowing of the medial compartment.
Also, there is joint narrowing of the lateral compartment.
Yes, so there is narrowing of the lateral compartment.
Narrowing of the lateral compartment, and there is also.
So what medical school are you? Are you year 1 student, year 2 student, year 3 student, year 4 student? Which year are you?
Sir, I am year 4. I have passed FCPS theory now.
Okay, so what you're answering to me is like a medical student. You know, you were supposed to be a consultant after you pass your exam, isn't it?
Yes,
so
sir.
do you not think that as a consultant you would know what an arthritis looks like? I'm not being funny, but in the exam, it's all about money. You have to score points. So what you can say, this is an X-ray, AP and lateral of the left knee, which shows lateral compartment arthritis on the AP view and patellofemoral arthritis on the lateral view. The medial joint seems to be, in fact, it's a bicompartmental arthritis. Okay?
Yes.
But in the exam, if you tell me that joint space is narrowed, there's osteophytes, and you're telling me exactly 5 things about arthritis, well, I expect you to know that because you come to do an FCPS exam, isn't it? Now, if you don't know that, then that's worrying. So you can't tell me all these things. You have to tell me straightforward. You have to go for the money. Isn't it? The money is, this is an AP and lateral view of a knee, which shows the lateral compartment arthritis and a patellofemoral joint arthritis, suggesting a bicompartmental arthritis. Okay?
Yes, sir.
Okay, so where do you see lateral compartment arthritis? Is this normal?
There on this lateral compartment is all narrowing and there is sclerosis.
I know, but is this normal? You normally see medial compartment because that's where you started with. You said this is a medial compartment arthritis. So normally,
I just for the reflection.
No, but osteoarthritis normally is on the medial side, isn't it?
Normally on the medial side, yes.
This is lateral side. So what is different here? Why is it lateral side? Did the age got you concerned? I did tell you she was very young. She was 48-year-old.
48 years. So I don't know.
Have you ever seen a rheumatoid patient?
Yes, I have seen.
Where is the arthritis in a rheumatoid knee?
Usually in the lateral compartment.
Exactly. So then you have to tell me that this patient probably is a rheumatoid patient.
Rheumatoid patient.
Okay. So again,
the rheumatoid patient, one of the findings that there are no much osteophytes seen.
Doesn't matter. But if it's a lateral compartment and you've got rheumatoid arthritis, it burns out. Then it becomes arthritic, and when it becomes arthritic, you will have osteophytes. So there is a very classical feature of rheumatoid in here. 2 things. First of all, is it's a lateral compartment. So what's this?
Cyst.
So what do you call that in a rheumatoid patient? Sorry?
I don't know.
It's called a geode. Okay, go and read geode. A rheumatoid cyst is called a geode. The synovial fluid collects into the bone, and it becomes a big, huge cyst. This is small, but you can see cyst as big as this. The whole one compartment is called a geode. That's a typical classical feature of rheumatoid. So this is a burnt out rheumatoid. So now if I was going to discuss this X-ray in the exam, I would say this is a 48-year-old left knee with a lateral compartment arthritis and a patellofemoral arthritis showing features of burnt out rheumatoid. Okay, now if you say that, in the first minute, you've scored the maximum possible points on that X-ray.
Okay.
You can talk to me about, joint space narrowing and osteophytes. I will listen, but you will not score anything because I expect you to, at an FCPS level, to know that what is arthritis and what does an arthritic joint look like. But here we're trying to see whether you're good enough to be a consultant and pass your FCPS exam, isn't it? So if to pass your FCPS exam, you need to tell me that much more.
Exactly.
Okay? So we're happy with this knee. If you see lateral compartment arthritis, and it's a relatively young person, it has to be rheumatoid. Why do they get lateral compartment knee arthritis?
Why do we get rheumatoid?
Yeah, why do rheumatoid get lateral compartment arthritis? So Rifat has raised his hand. You want to tell us something?
Increased synovial membrane, and there's a lateral compartment is a big in surface area than compared to the medial.
So where did you read that? I've never read something like that before, but have you read this somewhere?
Because there is a
No, the reason they have lateral compartment arthritis is because of the foot and ankle. You know, rheumatoid patients have got hindfoot problems, and when they have hindfoot problems, their weight bearing is not as good as what normal people have, which goes from the medial side of the joint. So therefore, a mechanical axis change, and they go to the lateral side, and therefore they have arthritis on the lateral side and wearing out of the lateral side. It is related because of the foot and ankle deformity they have, rather than what is happening here. Okay. There's a lot to know. You're going to be a consultant tomorrow, so you need a lot to know. You can't just tell me that this is a joint space narrowing with arthritis and with an osteophyte. You need to know a lot more.
Okay.
I just want to pick a nice one. Yeah, okay, go on then. Who's next?
Sir, may I?
Yeah, of course.
This is the gross picture of a patient in the anterior, upper aspect of the foot, and the anterior aspect of the foot, showing most obvious finding is there is a bunion, and there is overriding and pronation of the big toe and the hallux valgus, as well as clawing of the second toe.
Clawing. So why do you want to get yourself into trouble? All you guys say things to get yourself into. The examiner is asleep. You have to keep it in such a way that the examiner doesn't wake up. You say things, he gets interested in what you're saying. Okay. So don't say there's no clawing here. Where can you see clawing?
So on the on B picture, it looks like it is clawing.
No, don't say things like that. You know, just talk about the obvious things. Okay. So the obvious thing. This is a 4 foot of a man, because it is a man. Yeah, I'll tell you what they give this. It's a 4 foot showing hallux valgus with you said pronation, isn't it? Like pronation of the big toe.
Pronation and overriding.
Yeah, so you can say that this is hallux valgus with overriding of the toe and pronation. So why do you get pronation of the big toe?
Sir, this is basically due to the imbalance pull of the abnormal tendons.
So there is a muscle imbalance, and
Yes, sir.
because of the muscle imbalance, the hallux valgus deformity gets worse by the metatarsal, going in one direction, and because it goes in one direction, the tendon is not torn, so therefore it will pull it in the other direction and rotate it to allow it to balance it. Okay? In like rheumatoid, if you have a problem with a rheumatoid hand, because the hands have legs sag because of soft tissue, but the tendons are still intact, and they end up with various deformities such as swan neck and boutonniere and ulnar deviation, all that. That's because the tendons are intact. So this is because there's imbalance of the tendons, and it is going into one direction, and because it is now rotated, it's pulling it, and this is getting worse. So what exercise are you going to do? So what exercise are you going to do? Or do you know any markers that you can measure in here to see what you can do? There are a couple of angles you have to talk about, isn't it? How are you going to decide to sort this out? If this patient is medically fit and wants something done for it and has consented for surgery, how are you going to decide what you're going to do for this person? First of all, is you have to decide, does this person need an operation? And how are you going to know that? Nobody wants to talk.
We will do that to check for the angles.
Which ones?
We do X-ray AP.
No, you have to check for the hallux valgus angle, intermetatarsal angle.
Intermetatarsal angle.
And
we also do the distal metatarsal articular angle.
Fantastic. Okay. So what level would you decide this person needs a bunionectomy, this person needs a metatarsal osteotomy, or this person needs a distal correction with a soft tissue balancing, or this person needs an arthrodesis? How are you going to decide that?
But this is part of the grades of the LSO. This is further mild, moderate, and severe.
How? So how are you going to make that grade mild, moderate, and severe?
According to the measurements of the angles. They are
It's very clear, you know. I don't understand what you're saying. I know what you're saying, but as long as you don't tell me the right words, I think you don't know. That's what I'm going to assume as an examiner. Okay, so you have to tell me, you have to measure, and if the intermetatarsal angle is how much, that you will do a
9.
Okay, so it has to be a range. There is no such thing as one number, but you can say 9 to 11, right?
9 to 11.
Yeah. So if that is that what you will do in that case then? So you need to understand. You need to tell me what is mild, moderate, and severe. Okay. So what of the three angles that we just mentioned? Of those three angles, how much would be in a mild, moderate, and severe?
So if, just like helix valgus angle, if it is between 15 to 25, it is mild.
Okay.
25 to 40 is moderate. More than 40 is severe.
Okay. I don't remember the angles, but okay, you're right. Yeah. So what's the next angle you look at?
Next, we look for the intermetatarsal angle.
Okay.
Normally around 7 to 9 degree.
Good.
9 to 13 is the more mild, and 13 to 18 is more than 20 is the severe.
Okay. So if the patient has got severe helix valgus, what are you going to do for this patient then?
So if patient has a severe helix valgus, then we, along with the soft tissue procedure, modified McBride procedure, we also do the
Where do you do modified McBride procedure? Is it not in young people who have got interphalangeal deformity that you would do a soft tissue procedure? So if it's a big severe deformity, then soft tissue procedure is not going to help you, isn't it?
Oh, yes. Soft tissue procedure will be as an adjunct. We will have to proceed with the osteotomy also.
Okay, so there are three options. You can, well, four options. You can do nothing and let the patient have modification of his shoes. Okay. And you can something in between the toes to sort it out. The second option is that you can do a procedure where you take the head of the metatarsal out. What is that procedure called?
Head of the metatarsal out.
Sorry?
Multiple procedures.
Tell us, yeah?
There is sharp, block.
So nobody's saying anything.
Hello.
Yeah. Keller's procedure, yes?
Yeah.
And chevron osteotomy.
No, hang on. Don't put your names in it. The question I will ask you is, what is a chevron? So what I will say is, the first option is do nothing and give them spacers. The second option is the third option.
Yes, sir.
The third option is arthrodesis, and the fourth option is I can't hear everybody. At the same time.
I would say like this: if patient is asymptomatic.
Sorry.
May I continue?
Yeah, of course you can. Yeah, everybody wants to talk at the same time. Yeah?
So the other guy, I think so, has some trouble. So we will look for the intermetatarsal angle and helix valgus angle. Intermetatarsal angle will normally it's 9 to 13.
Yeah, we've already discussed that. So we need to see moderate or severe. Yeah?
Hello.
Yeah, we need to know whether it's mild, moderate, or severe.
Yes, mild, moderate, and severe. Accordingly, and joint congruity, we would have to look at the joint congruity also.
And also an X-ray to show it's not arthritic. It's very important. You can't do an osteotomy and a soft tissue correction. It's not arthritic.
If the joint is arthritic, then
see, one of your guys is not working. So why do you want to continue with it? You can stop it. You're disturbing everybody else.
I think I cannot hear you very well.
So it's not working, guys. I mean, you need to understand. You can't disturb it.
Yes.
Telephone and system is not working. You go off, and so everybody else can do it. But, okay.
Yeah. So if the joint is arthritic, then procedures would not give a pain-free joint,
Exactly.
and we would have to do resection arthroplasty or arthrodesis of the
Come back to
joint.
injection. So you're saying things to make me wake up again. So why do you want to give an injection here?
Resection arthroplasty.
Oh, resection. Sorry, I thought you said injection. Yeah. Okay. Yeah, you can do resection, which is colors, or you can do a fusion.
Or joint arthrodesis.
Fantastic. Okay. What else can you do in an arthritic joint that is painful?
Arthroplasty.
I've not seen many arthroplasties in the big toe. Don't work because there's a lot of forces going on. Yeah. But what you can do is modification of shoes. You know, orthotics.
Shoe modification. Well, I have never practiced anything like that, and I don't know.
Okay, but
if you can tell me.
You can give them spacers, and you can give them metatarsal bars in the shoes, so it allows to take the weight off them. Okay, so some patients are not to have an operation. So if you are doing an osteotomy and it's a severe deformity, what osteotomy do you know?
I know chevron, I know scarf, and I know Atkins.
So what's the difference between the three?
Chevron is done when the deformity is mild. It's the distal osteotomy. It's a chevron cut of the metatarsal head.
So if it's a mild deformity,
chevron cut.
Osteotomy. Very good, yeah?
Yeah.
Next.
Yeah. In the moderate deformity, we do proximal metatarsal osteotomy, in which we take the osteotomy is like it's a Z shape of osteotomy.
Okay.
Going all the way.
Why do you want to do a proximal and a distal osteotomy depending on the deformity? What is your Are you correct? You're absolutely.
It's the range of the correction which is achieved with the
longer lever arm.
Sort of
it's a longer lever arm. The more proximal you are, the more the lever arm is longer, and therefore the deformity correction is better. Okay.
Yes.
So
and if there is an intermetatarsal instability, then we would have to do a Lepidus procedure to fix the more proximally.
Sometimes the metatarsal joint is done as a secondary procedure in hyperelastic feet, not in arthritic feet. Yes. So you have to be very young, and you have to have Beaton's criteria of 9 or something like that for the Lepidus procedure to be done. Yeah. So understand that if it's a young person and multiple jointed and hyperelastic, then you also need to do a soft tissue procedure. However, if it's an arthritic old person with a very severe deformity, the soft tissue correction in that is not going to help, because the soft tissue was never a problem. It was just the shape of the metatarsal.
Yes.
Okay.
And then there's an Atkins osteotomy, which is done at the interphalangeal joint. It is the lateral medial closing wedge sort of an osteotomy to realign the interphalangeal axis.
Very good. Yeah. So you need to understand this. I mean, I'm not a foot and ankle person, but you need to know quite a lot of these things, and you guys have done well. It's just you need to understand what answers you have to make, isn't it? Yeah.
And all of these bony procedures would require lateral release of the capsule and realignment of the sesamoids.
Okay, but not necessary. But yes, you can do that. Yeah. Just one more. I need to find a nice little case for the last. Okay, so this is a athlete. He is right hand dominant. Okay, and he comes to you. That he goes to gym, but for the last 4 or 5 weeks, his elbow on the lateral side is very painful. Okay, so what do you think is happening here? I don't mind. Who wants to go? Nobody wants to go.
It could be a tennis elbow, considering an lateral epicondylitis of the patient.
In the exam say it is lateral epicondylitis. If you say tennis elbow, then everybody starts talking about, well, you don't use the lateral epicondyle in the tennis, so why is it called tennis elbow? So no controversies in the exam. This is lateral epicondylitis. Okay. So what is lateral epicondylitis?
It is the inflammation of extensor carpi radialis brevis origin at the lateral epicondyle.
Every time.
Mm, Usually it's EAC, RB, or external, common external, common extensor, we can say.
So it is the attachment of the common extensor origin, which is rubbing against the epicondyle, and the bursa underneath has dried out.
Okay.
Okay. So what symptoms do they present with?
Resisted elbow extension and would be painful in radial direction.
Is what, sorry?
Tenderness at the lateral epicondyle and just below the lateral epicondyle, and resisted elbow extension.
There are 3 tests you're going to do.
Radial elbow extension would be painful.
So there are 3 tests you do for tenderness. What are those tests?
Okay.
There's a Mills test, there's a Cousins test, and a Chairs lift-off test. Yes?
Yes.
So what are those?
Specifically, I cannot. Mills. Anybody else can help?
Did anybody tell me what is a Mills, what is a Cousins, and what is a lift-off test? So if you're trying to lift yourself out of the chair by pushing it with your hands and you get pain, that is a lift-off test. And then Mills and Cousins, we are talking about epicondyle. So if you keep your hands stretched and tight and you don't stop allowing flexion, and if that's painful, then that's called a Mills test. And if you can do it passively, flexion of the wrist, and it's painful, then it's called a Cousins test. Okay? So Mills, Cousins, and lift-off test. How do you treat these?
Rest, ice, and NSAIDs, restriction of activity.
What, sorry?
Rest, ice, and NSAIDs, restriction of activity.
Okay, so the first thing is to give them rest. The second thing is to take the pain away, which gives them non-steroidal anti-inflammatory medication. And third thing is you can use additional straps. As you can see here, there's a tennis elbow clasp going on here. Yeah. So now, if it doesn't get better, what's the next stage then?
We can give a local injection of a steroid.
So how does that work?
By decreasing the inflammatory markers, inflammatory cycle over there.
So what happens then? So it doesn't go away. It just makes it a bit less.
Mm-hmm. If it is not improving, then we can do.
No, I didn't ask you the question that. I said, how does it work? So it works by breaking the vicious cycle of pain by giving a local anesthetic with a steroid. You have to do it with the process of needling. Do you understand what that means?
Process of?
Needling. If you take a needle with a local anesthetic in it, you have to go into the epicondyle and go forward and backward a few times to make it bleed. That's called needling. If you don't do that, the steroid is not absorbed properly, and therefore they don't have the function out of it. Okay, so the steroid basically stops the inflammatory mediators such as tumor necrosis, factor alpha, and interleukins, and all that, which is causing pain. So by stopping that, you stop the repair process, and therefore they have no pain. And then they break the vicious cycle, and the physios help them, and they can get better. So if you've done an injection and it doesn't get better, what are your next options?
We can do a surgical recession of the tendon slide.
Done. What else can you do? What is the latest modern treatment for these now, which is evidence-based?
Arthroscopic debridement of the ECRB tendon.
No, you can do it open. You can do it arthroscopic, but open and arthroscopic, same thing. What's biologics here? How does biologics work?
PRP?
So how does that work? Yes, PRP is correct. Do PRP, but how does it work?
So because PRP contains both factors that will accelerates the healing.
So the PRP will accelerate the healing of the what?
Of the tendon.
No, the bursa. You know, there's a balloon up there from which the tendon is rubbing against it, and it will try to recreate normal anatomy. So if you look at evidence, there is evidence of PRP in tennis elbow, which is level 1 evidence. There is no other evidence of PRP in anything else. You don't know in arthritis, no fat in knees, no nothing at all. There's no evidence. The only evidence means putting PRP in tennis elbow. So in the exam, you will say, I will manage this patient non-operatively with some rest, anti-inflammation, maybe some clasp and physio. If the patient is refractory to that treatment, my second stage would be needling with some sterile local anesthetic and allow the physios to work with it. If that doesn't work, I will discuss with the patient and opt for surgery or an intermediary procedure such as biologics injection of PRP into his tennis elbow. Okay?
Okay, sir.
Yes. Thank you very much.
We call it a day, and I think there's enough for everybody to take. I think we'll do another one on Sunday if everybody's ready. Yeah. Yes.
What was the question?
No, the question is done. We will do this we stop now and we'll come back on Sunday and do another 15, 20 minutes, half an hour, 45, depending on how it's going. You guys need to stop. You're very...
For inshallah, on Sunday I'll be there.
Okay, we'll talk on Sunday then, inshallah. Okay.
Okay.
Thank you very much.